this week on the BackTable Podcast.
My mom was in the ICU for 6 months, and they wouldn't give her her home dose of vaginal estrogen because they said it causes blood clots. And we know it doesn't cause blood clots or stroke or heart attack or probable dementia. And she had a catheter. She was in a coma for so long. She was immunocompromised. And I said, you have to give her her home dose of vaginal estrogen. And they said, but don't you know your mom is sick? I said, of course I know my mom is sick. That's why I want her to not get a UTI and die of urosepsis. And so I had to fight. I had to put together a whole presentation. I convinced one team, then I had to convince the ICU team, and everyone kept saying, but it causes blood clots. Then I wrote the prescription myself with them watching in the EMR, and the pharmacy wouldn't dispense it because they said, wait a minute, we got an alert that this causes blood clots. We can't give this to your mother. Finally, the tube of estrace made it up without an applicator, and the nurses said, we don't know what this is and how to give it. And I had to roll up my sleeves and show them myself.
I'm your host again today, Dr. Suzette Sutherland, and I'm thrilled to have with us here Dr. Rachel Rubin's here. She is a national and international expert, really, in urology and the topic specifically of sexual health, both men and women, and nationally advocates for many aspects of sexual health. So we're excited to have you with us here today, Dr. Rachel Rubin.
Oh, thank you so much for having me. I'm so thrilled that you are doing an entire series on this topic. This is my third time back to your podcast. And I will say I've done a lot of podcasts, but nothing is used in my family more than the BackTable Urology sweatshirts. I just want to say that.
Oh, wonderful. Hopefully they're listening to them as well, to the podcasts, right? So a little about Dr. Rubin's. She has started a specialty urology and a sexual health practice in Bethesda, Maryland. So that's where she is currently. She also trained in that area, doing urology training at Georgetown, and then sexual medicine, further specialty education with Irwin Goldstein in San Diego, who we both know well. So she's very highly qualified in the area of sexual health, as well as other urological aspects as well. And again, for both male and female sexual health. So that is the really more unique aspect here, I think, which is really interesting. So as Dr. Rubin's mentioned, we are doing a menopause series here on BackTable Urology. We've already recorded a number. One has already been released. That's the first one where we talked about the WHI studies, or Women's Health Initiative, looking at the fallout that happened from that and demystifying many aspects of it and exploring the truths, what we know today and what we're doing about that. Another one looks at the black box warning for vaginal estrogen, getting that black box warning off, which Dr. Rubin's has been very involved in, and doing something in a number of days, right? Meeting with the FDA to work even further on this mission. Is that correct?
Yes, we're very excited.
And then we have another one where we're looking at the genital urinary syndrome of menopause. That's what it's called now. And looking at our AUA SUFU guidelines, practice guidelines. How should we be managing women who have GSM, or genital urinary syndrome of menopause? And this episode here today is really looking at the how-to of hormone replacement therapy, but not vaginal. We can talk some about that as well, but more systemic hormone replacement therapy. And that's what we want to dive in here. And I'm going to start it off by saying, acknowledging, because of a lot of the fallout, I think, from the WHI studies, and all of these women and even providers felt that the data shows that there's so much risk associated with systemic estrogen that a lot of people then didn't prescribe it. Not only did women not want it, but many people didn't prescribe it. And so we wonder, who knows how to do it today? And, maybe you can shed some light a little bit further on that story about how we got here, looking at how many people are able to successfully or effectively prescribe, we'll call it HRT. It's easier to say than hormone replacement therapy repeatedly, right? Versus people who are just sort of dabbling. And what women should look for then.
Yeah, so it's such an important question. And I think we are really struggling here. Even though we're getting louder, we're getting more emphatic that maybe the data was not interpreted correctly, we're actually running into some really big problems because you have an entire generation of clinicians who have absolutely no idea how to do this, the nuances of doing this. And it's a disaster because it does take, it's not hard, right? I'm a urologist, of course. If I can do it, anyone can do it, but it's not complicated. But when it's everybody's problem or everybody should be doing it, like nobody does it. So nobody has really championed this field of menopause medicine, which should not be a niche field of medicine, right? This is 50% of the population. So to say, right, and we know the data is very clear, less than 6% of internal medicine, OBGYN, or family practice gets really any training at all in menopause medicine. There's a couple other papers, maybe 20% of people get an hour lecture here and there. I mean, it's very clear. I certainly did not get any in my residency training or my medical school training. Do you remember getting much?
No, absolutely not. I think when the whole era came out with testosterone and possibly using some testosterone in women or Viagra for women, and many people got involved in sexual health in women, female sexual dysfunction, we called it back then self-educated, right? To learn about it. But no, did not learn.
The challenge is, so I have a theory, right? It's actually worse. The data shows they presented at the Menopause Society meeting last year, and we are worse today in terms of the percentage of patients on hormone therapy. It's like 5% or less. It's less than 5%, and that's worse than 10 years ago. And the reality is why are we worse than 10 years ago? The Women's Health Initiative came out in the early 2000s. Why 10 years? And I think it's because a generation of doctors who knew how to do this pre-Women's Health Initiative, they retired, right? And these were doctors who were in their clinics. They were, living the good clinic life. The residents spent no time with them. They didn't get time. But the residents were busy in the operating room or delivering babies or sort of doing the ICU work and things like that. So you have an entire generation of doctors that don't have the skills and also have no idea that this is their responsibility because we as a medical community have not given anybody the responsibility of doing this. And so the problem is menopause has a terrible PR campaign. It's actually all marketing. Every problem we have in menopause right now is marketing. It's bad marketing. And so what we have really tried to do is kind of repackage it of like, wait a minute, the benefits definitely outweigh the risk. Vaginal hormones are safe for every human on earth. And now it's actually a urology problem. We are turning GSM into a urology condition. We expanded it beyond gynecology and atrophic vaginitis or a little vaginal dryness. And we made it about urinary tract infections, which, as all of your listeners know, kill our patients all the time. And so we have a big problem in a lack of training. And the challenge is if you give mandates or you say everybody has to learn this or this needs to be in the medical school curriculum, who's going to teach it? Who are we going to trust to teach it if they how are we? And we find that problem sort of certainly in urology residencies is we have an entire curriculum, AUA curriculum in female sexual medicine. But if there's no faculty to teach it, it's not gonna trickle down.
Yeah. Along the same line, then, when you're looking at residencies, let's break it down at that level rather than in medical school and getting sort of a basic lecture about hormones. I think that's necessary, right? Everybody should be getting that no matter what specialty you go into or general. But when you look at residency, who do you think that this should really fall to predominantly? GYN or internal medicine? I mean, urology really, there are urologists who might be interested in doing this too, people who specialize in female urology or sexual health, but a lot of urologists I don't know that would feel absolutely comfortable with something like this and whether that would fall under their main domain. What are your thoughts about that?
I think the reality is it should be looked at by anyone who takes care of women, period, end of the sentence. And so truly, we should all know about it. So it's really important that cardiologists understand hormone therapy and how it affects the heart. Holy hell, is it important for neurologists to understand the difference between birth control pills and transdermal estrogen or I had a neurologist, one of the smartest neurologists I know recently said, wait, my patient has migraine with aura. Can they take vaginal estrogen? And I want to slam my head against the wall of like, this is a very intelligent neurologist. So for ICU doctors, we need ICU doctors to know what the difference is between hormone therapy and why it's not all the same thing, or the difference between a hydrocortisone cream for a bug bite and IV solumedrol. They're all steroids, but they're very different. The same is true for hormones. And so by not teaching the internal medicine doctors, the family practice doctors, the OBGYNs, of course, OBGYNs should feel confident about this, but they should not be the only ones responsible because we're urologists. We are not the only doctor who sees men. That's a ridiculous concept. No man comes to see me for his heart problems or his brain problems, right? And so the idea that gynecologists are the only doctors who even touch women, or that we get to say, ooh, that's the lady parts. We don't do lady parts, right? Is misogyny. That's the way medicine works. It's misogyny, and we have to call it out, like we see it. I would argue urology plays a huge role in menopause. I think the things that kill our patients. So honestly, the two specialties where I think should actually be championing menopause are probably the two least likely. Orthopedic surgery, because women are dying of fractures. They are dying of osteoporosis and fractures. And urology, because women are dying of urinary tract infections and their pelvic floors are disintegrating, which is going to lead to incontinence or frequency, urgency, pelvic pain, interstitial cystitis, and all of these other hormone-based conditions that hormones are often ignored.
Yeah. But do you really think that an orthopedic surgeon should be prescribing systemic estrogen, progesterone, or just know enough about it to recognize, hey, this woman needs it, and then let her internal medicine provider handle it?
I have a dream that an ortho's checklist, you remember the days when people, I don't know if they still do this anywhere, but they used to do bacitracin or something in the nostrils to get rid of MRSA before surgery,
Yep.
right? Like I have a dream that before a hip replacement, they're checking boxes and they use orthopedic estrogen, which is a little vaginal estrogen insert 2 months before their hip replacement, that we'll call it orthoestrogen, right? Or this idea of, if we believe in the musculoskeletal syndrome of menopause, which is all the frozen shoulders, that hormone therapy is a tool like Celebrex to decrease inflammation and help. And so I think, this idea of who should be responsible, I think we're watching it happen live with GLP-1s, right? This idea of who is responsible for prescribing GLP-1s. And I bet you from what happens today to 10 years from now, there's going to be a lot more that I see OBGYNs starting to prescribe. I see, all sorts of different types of clinicians trying to prescribe these things. And they skipped over hormones. They said, why are we starting with those when hormones are much safer, much longer understood, and actually a really big part of the toolbox that we're completely ignoring?
Yeah. Yeah. I love that analogy, looking at this all medrol, right? And the point you're making there, obviously, is the difference between systemic versus local, right? And so that's
and dose, right? Dose and
Yeah.
and formulation, it matters.
And that first dichotomy, the systemic versus vaginal, right? Local, vaginal in this case, is the first huge dichotomy that people really need to understand when they're looking at a lot of the data associated with risks and benefits of estrogen and other hormones. So along that line, why don't you why should women be? What did the WHI's studies really not say, if you want to, they talked about some of the risks of estrogen, but there are a lot of risks of not being on hormone replacement therapy. And you already mentioned a few of them right there.
I love this idea of the risk. We talk all the time of what are the risks of this medication, but what are the risks of not taking this medication? If you get someone with horrible overactive bladder and you're painting a picture for them of, here are the risks of these medications, dry mouth, constipation, maybe cognitive issues, or sort of, this is your risk of retention, or these are your risks. What are the risks of untreated overactive bladder, right? You're running to the bathroom all the time. You wake up in the middle of the night to pee and you fall and break a hip. Right? What is it doing to there's so many risks of not doing something and risks to people's quality of life. Now, hormone therapy is a fascinating topic because everyone obsesses over the risks of taking it, which are totally overblown. And most of the data we actually don't know. The reason I say that is because the bulk of the data that we have is from the Women's Health Initiative. The bulk of the sort of randomized placebo control, very long-term trials is from the Women's Health Initiative. And that is one pill, one dose. That's it. And I don't ever prescribe that pill or that dose of medicine. And it's not even similar to the hormones that I prescribe today. So when we talk about risks, I actually always have to tell my patients that I actually really don't have major data to show you risk. I have lots of sort of observational data to show you benefit, and I have ways to extrapolate the data from the Women's Health Initiative. But the Women's Health Initiative used a birth control style pill of synthetic estrogen and synthetic progestin, sort of like it would kind of be like the difference of a bodybuilder coming in and talking about oral anabolic steroids compared to transdermal testosterone. Those are different medications with they're both androgens, if you will, but they work differently in the body. They're processed differently. They go through the liver differently, and they're actually measured differently. Like you can't really measure an anabolic steroid in your bloodstream unless you have very special tools, but you can measure testosterone in the bloodstream. And that is the difference between these synthetic oral hormones that they used in the Women's Health Initiative compared to the more what we call transdermal or bioidentical forms of the hormone, which are also FDA-approved versions of them.
Why don't you just said use the term there just for our audience. Can you break down the bioidentical?
So for example, if you take a bodybuilder who's on oral anabolic steroids, right, and you measure his bloodstream, you can't measure that level of anabolic steroid in his system. That is not a bioidentical product. But if you give the gym bro some testosterone, whether it's a topical cream or an injectable or one of these oral pills, you measure his blood and you can look at his level of testosterone. You can see it change and rise and fall with your dosing. That's bioidentical. It's very simple. If I give a woman a birth control pill and I measure her estrogen and testosterone in her bloodstream, it has nothing to do with the birth control pill dose that I've given her, because you cannot measure birth control in someone's bloodstream because it's a synthetic form of the therapy that you're giving her. Whereas if I gave someone an estrogen patch or a testosterone cream, I can then measure her levels in her bloodstream, which is a bioidentical product. So it's really important because they're not the same thing. And so actually one of my favorite menopause warriors is this doctor in Britain who's married to a urologist, by the way. Her name is Louise Newson. And she gives this analogy, which I think is so brilliant. And she shows patients a picture of a strawberry. And she shows patients a picture of a gummy strawberry, like a Haribo gummy strawberry. And she says they're both called strawberries. They both smell like strawberries. They both look like strawberries, but you cannot compare the nutritional contents of one and the other. So when a study comes out and it says hormones cause cancer or hormones cause blood clots, you have to look at the fine print. Were they studying strawberries or were they studying gummy strawberries? No, you cannot talk about the health benefits of a strawberry, but use gummy bears as the medicine, the thing that you're giving people. And it's so simple. So when a patient comes to me and says, "Oh my gosh, I read this headline," I say strawberries or gummy strawberries, right? And if you lump them together and you have a giant bowl of gummy strawberries and strawberries, what does it mean? Are you there to say strawberries aren't healthy? Because that's crazy, right?
Yeah, which is how much of our, combined science is, right? They lump all of these studies together that look kind of like they're the same, but they have different products and they think they come out with an answer. So it's really not appropriate methodologically.
And we want our doctors to know everything and to be able to interpret research. But as we all know, we all also read the conclusions and the headlines and the snippets because we're all very busy and we can't actually understand the nuanced data for everything. And so it's really dangerous, right? Because an entire generation thinks that hormones cause cancer and blood clots and strokes, in fact, when it doesn't do those things.
Yeah. So let's move into that. I mean, again, we have another episode that we really looked at a lot of the data of the WHI study, but maybe you can just outline, here's what they said they thought was true, and then what we know today what the benefits really are.
Yeah. So there were two arms of the Women's Health Initiative. So any woman with a uterus needs both estrogen and progesterone or a progestin. And if you don't have a uterus, then you don't have to have a progesterone or a progestin. You could just use estrogen. So they had women without a uterus just took a synthetic estrogen, and then women with a uterus use a combined estrogen progestin. And in the estrogen only group, right, when you take an oral synthetic hormone like a birth control pill, you can see an increase in blood clots and pulmonary embolisms, which you see with birth control pills as well. And when you looked at women and the average age was 62 in the Women's Health Initiative, you did see an increase in blood clots and DVTs and PEs in both groups. But in the estrogen alone group, you saw a decrease in coronary heart disease, a decrease in stroke, a decrease in getting or dying from breast cancer. There was a decreased risk of colorectal cancer reported. This is crazy. A decreased risk of all cancers, all fractures, death from any cause, and diabetes and fractures. Well, I said fractures. Diabetes by like a good, like super, super decrease in diabetes. Now, that's crazy. Those stats, that data. I spoke at the Internal Medicine Conference, the ACP conference this year, and there was not a single lecture or course on menopause hormone therapy. And it's insane. Like, I talked about it a lot in my sexual medicine talk, but like, how would an internist not want to know that this medicine that has been around for decades decreases diabetes, death from any cause, and fractures? Like, it's pretty wild. Those who took the combined medicines had a slight increased risk, again, of the DVTs, the PEs, slight increased risk of coronary heart disease and stroke. There was a slight increase, extra 6 per 10,000 incidence of breast cancer, but not death from breast cancer. And then a decrease of colorectal cancer, all cancers, all fractures, death from any cause, and also diabetes. And so people went nuts and said hormones cause cancer when the estrogen reduced your risk of getting and dying from breast cancer. So the fear is actually around progestins more than they should be around estrogen. But today's medicine, we don't give progestins, we give progesterone, which is, again, gummy strawberries versus strawberries. And we also don't give oral estrogen, we give transdermal estrogen typically, which gets rid of your risk of blood clots. So it's wild because when a woman comes in and says, what are my risks? I kind of have to do a little bit like, we don't actually know fully what your risks are. We don't fully know. I can't give you a stat to say this is your risk of getting a stroke because actually when you did it early before age 60, like there was no increased risk of stroke. And when you did it after age 60, it wasn't that high either, even in the oral estrogen sort of group.
And yet, in spite of all of the benefits that we found out, the headline, to your point, we're all very busy and we just read that last line, right? Or the media headline was it increases breast cancer and thus the scare and why so many women came off of all of their hormone replacement therapy and then providers being afraid to prescribe it.
And I actually think that urologists can understand this more than most because we were all raised in the generation of testosterone causes prostate cancer. And it wasn't until the one guy, A. Morgan Tyler, kind of pushed back and said, well, the data is actually not true. And there's this saturation model, and we can actually give testosterone with a history of localized prostate cancer. But we have a marketing problem in that we don't call prostate cancer testosterone-sensitive prostate cancer. All prostate cancer is sort of testosterone receptor positive prostate cancer. But we call all breast cancer, we classify breast cancer as estrogen progestin like receptor positive, which gives that indication that those things cause the cancer, that was the problem. And so again, everybody is just so afraid.
Well, with that in mind then, trying to put the fear aside. I mean, I get as education, right, is power, right? And just trying to educate people about the truth about the WHI studies, all the things that you've just said, and then how to move forward safely, right, for women. So let's move into that. And how does somebody start then if they haven't really been prescribing this? They've heard about it, estrogen, progesterone, who needs to know a little bit about it, but the teaching was always then there after the WHI. If you're going to put a woman on hormone replacement therapy, the smallest dose of estrogen to get the job done, i.e., so she wasn't having hot flashes, night sweats, and mood swings, and for the shortest amount of time necessary, and certainly not any longer than about 10 years. But we know
Yeah.
that's not true either.
Yeah, and even the most conservative guidelines no longer say that. And so if you ever have a doctor or you're a doctor who says, "Oh, lowest dose for shortest amount of time," you need to re-educate yourself on the data. And it really, so I always tell my patients when they say that, I say, "Okay, tell your doctor one question." I say, "When does Caitlyn Jenner stop her estrogen?" Right? She's 75 years old at this point. When is it not safe for Caitlyn Jenner to take estrogen? And the answer is no one's going to tell, well, politics aside, like no one's going to tell Caitlyn Jenner to stop her estrogen therapy. And so the reality is there is no reason to stop. All the bone benefits that you get from estrogen go away when you stop estrogen therapy. We are very clear in the GSM guidelines, as you know, is that this is lifelong therapy. You never stop your vaginal hormones. If you want your UTIs to come back, stop your vaginal hormones. I don't know who would want that, who would want to start leaking again and getting infections again. And so the hormone therapy's benefits are to help with the vasomotor symptoms, the hot flashes, the night sweats, but the bone protection, the osteoporosis prevention. And, that's only going to work as you keep using your hormones. And so the data seems to show, now we need more data, there's no question, but the data seems to show that when you start it before 60, within 10 years, that it's very supportive of the vessels. And so you get some cardiovascular benefits. You get that Alzheimer's, potentially the brain benefits, because your vessels haven't hardened and they aren't full of plaque. The worry is that if you start it after 60, sort of 10 years after menopause, that maybe you've built up some plaque in your arteries, and that maybe that if you use estrogen, the plaque could destabilize and could cause problems. But we don't have enough data that is like a certainty. And so there are people who think that it may, if you start it later, it could worsen dementia or Alzheimer's. But there are many who think if you start it early enough and you keep going, that it's absolutely brain protective. And so I'm so thrilled that there's so many more people than just a very small community talking about this, because we need more research. We need more data. We need more scans. I mean, there are scans that just came out that looked at, estrogen receptors in the brain. And this data was published in 2024. And literally, with even 65-year-olds, the estrogen receptors in the brain increase, not decrease, right? Because the brain is so hungry for hormones. I just learned recently that apparently neurons make estrogen. And so the brain can actually make its own estrogen because the brain is so in need of hormones and neurosteroids. So I think we have a lot to learn.
Well, we were talking about how we move on into actually prescribing. If you're talking to somebody and start with the estrogen, let's just presume she doesn't have a uterus. We don't have to worry about the
Yeah.
progesterone component. Most people in this audience, I think, recognize that concept. So you want to start on estrogen. What do you start with? What are the options and how much? And how do you know it's enough?
Yeah, so I actually started a course where I teach clinicians how to prescribe hormone therapy, because there aren't enough courses that are like, okay, here's how to do it, here's how to write the prescription, here's what to do. So we started our own little CME course that anyone can take. But what I teach on it is I do a big teaching of the Women's Health Initiative, sort of the spiel, the why it's safe, and then we talk about the 5 treatments of hormone therapy. And I think the big ones, right? So if we go through the 5, it's systemic or whole body estrogen. If they have a uterus, it's progesterone. If they have GSM, which everybody has GSM if they're over 40, give them vaginal hormones, right? Then there's testosterone, which you can do for libido. That's systemic testosterone. And then the extra credit one is the vulvar vestibule, where we put a little hormone on the vulvar vestibule for pain with sex, interstitial cystitis, sort of all of those things. So that one's a bonus. Estrogen is really the workhorse, right? It is the thing that fixes hot flashes, night sweats. It protects the bone. It can help with brain fog. And so you're going to want to think about the whole body estrogen. I use in my practice, I don't use oral estrogen, although it's not as dangerous as everybody says. Why increase any risk at all? So I like patches. There's gels, and there is a ring. Many of the listeners have heard of E-string, but there's another ring called Femring, which is a higher dose ring that can treat both the GSM and the systemic estrogen, unlike the E-string, which is just local. So basically a patch, you can start at a 0.05 milligrams twice a week. It's a really good place to start because it's kind of a medium dose and you can go up or down. Estrogen can cause breast tenderness, so I don't like to go too high, at first, but certainly you can start there. There's gels as well. There's different brands of gels. So there's gels you can put on your arm, your leg. There's an aerosol spray. it's finding a couple of products that you know about so that you can kind of learn the menu. And I think again, the more people you hear do it, the more you can get a sense of how people do it. We had a very popular podcast we did with Peter Attia where we spent 2 hours kind of going through the nitty gritty, right? The playbook, and you have a menu. You just like with OAB medicines, if one doesn't work, you've got another one that you can try and you can kind of tinker with it. So estrogen, there's a little bit of choice. There's a lot of doses and there's a little bit of choice. I personally love a good medium dose patch twice a week and kind of work from there.
What's a medium dose then?
I do typically get 0.05 milligrams twice a week and I like twice weekly patches. The once weekly patches tend to be very big and kind of annoying for patients. So I like the twice weekly patch.
So if need be, it comes in a smaller dose.
Sometimes I'll have them get the 0.05 patch, cut it in half. So it's like a 0.025 to start with. If you start someone with a 0.025 patch, they're going to use it and they're going to be like, but I still have hot flashes. They're going to be like, I'm still not sleeping. And they're going to be like, hormones don't work for me. And they do. It's just I see too many people try to dip a toe with hormone therapy. And the thing I say all the time to when I teach people how to do this is, what are you afraid of? What are you worried about? What are you so scared of that you're afraid that you're only dipping a little toe or you're like giving a little tiny, it's the urologist, if you're listening and you tell people to take a pea size of estrase and put it on the urethra and that's all they use, I'm yelling at you. What are you afraid of, right? They need more. They need more to make the vagina acidic. They need at least a half a gram or a gram in the vagina twice a week. And so when you tell the patient to just put a tiny dose, just a little bit, you're giving her the impression that you're also scared and you also think you're going to give her cancer, but you're not. This is not what we're worried about.
So what things have again, most people are thinking about the vasomotor issues associated with menopause. So if you give a woman 0.05 and she's still having some hot flashes,
I'll go up. So you increase, right? So you can increase. So typically, if you're starting out in hormone therapy, and for your listeners, some of them are going to be super nervous or it's not their lane, you got to hear multiple people talk about this. You got to get you got to kind of listen to people who are doing this. It's not hard. It's just repetition. You need to hear it a lot. For my young patients, it's very common. I have them on 0.1 patches, right? That's kind of the higher dose of the patch, 0.1 twice a week. If you got a 60-year-old, you're starting, don't start with the hard patients. Don't start with the patients where you're worried or it's questionable, right? Get used to the 52-year-old with hot flashes and isn't sleeping and work with her and you will see her life transformed. You will see magic happen in front of you. And I tell you, I actually, it's kind of funny because I have a sexual medicine clinic. So I have a clinic of really 3 big patient populations. I see a lot of pelvic pain, I see a lot of menopause, and I see a lot of men's sexual health. And when I tell you my menopause population is my joy because they get better immediately and I am like literally their favorite. I fix their marriages, I fix their work situation, I fix their sleep, I fix their relationship with their kids. I am a hero. And so because I have that variety in my clinic, I can get through the day because sometimes the other 2 populations of patients are a little bit trickier, right? We do a great job, but it takes a little longer. So the menopause is like this nice, easy, and for all of you listening, if you give testosterone, if you're a testosterone prescriber for men, 80% of the time when you've got a guy with low T and you give him that injection or whatever it is, you change his world. It is so satisfying. And to do that to a bunch of 50 and 50-year-old, late 40s and 50-year-old women is literally the joy of a lifetime.
All right. Let's say, you started off with the patch and it's helping for some of the symptoms, but not really all of the symptoms. They're still feeling maybe having a hard time sleeping, or which symptoms are you looking for to say, yes, this patch is right for you? But we know there are a lot of symptoms associated with menopause, right? And where do we draw the line to say we need to add something here?
So again, we're really always thinking about sort of the 5 things that we're thinking about. So if they're having any genital or urinary symptoms, they need vaginal hormones. So this is a really important point, and it's guideline number 11 in the GSM guidelines, is that if you have a patient on a patch or an oral estrogen or a gel, they need to be screened for GSM, and you need to be adding vaginal hormones to their regimen. We find it's often not enough. So you'll get a patient who says, Dr. Rubin, my hot flashes are gone, but I still have pain with sex. And you're like, yeah, because that patch is just not getting to the place where it really, we don't know why, but it doesn't get there. So adding vaginal hormones does nothing to increase risk. There's nothing to be afraid of. You're not giving too much estrogen. It's not overdosing. It's not that serious. The book says never check labs. But actually, I am a big believer in labs, in getting blood tests, because it's really helpful to not be afraid of things. So we know that men's estrogen levels are 25, right? 25 picograms per milliliter. When you check someone in menopause, their estrogen is 0. It'll say less than 5, which is the lab value you'll get. When you put someone on like a 0.05 patch, you get their estrogen level to like 40, right? Maybe like 40 or 50. Like, it's not that scary. Pregnant women's estrogens are 3,000, right? They're running around with these high estrogens of 3,000. And so when someone says, well, can I use estrogen in this situation? My patient has a history of this, but my patient has a history of this, or my patient has a history of that. My answer is, would you let the patient get pregnant? Because then her estrogen would be 3,000, right? Would you allow her to allow this patient to get pregnant? Would the treatment for this condition be to remove this woman's ovaries? Is castration the answer to her problems? If not, what are you frickin' afraid of giving back a little estrogen? So take a woman with a migraine with aura. She's been living with a migraine with aura her whole life, and she's been fluctuating from an estrogen of 50 to 150, 50 to 150. And then when she was pregnant, it was 3,000. Then it went back to 0 when she was breastfeeding, then 50 to 150, 50 to 150. Throwing an estrogen patch on her to get her estrogen to 50, what are you afraid of? Like, I'm afraid of nothing. Yeah, and keeping it stable the whole time, I'm afraid of nothing. And so that's where I talk through with patients patients and clinicians of sort of what is it that you're, so you've got the estrogen, which can help with hot flashes and night sweats. It can help with mood. It can help, transdermal estrogen can help with libido a lot more than oral estrogen because of the way of SHBG works. And so transdermal doesn't increase sex hormone binding globulin the way oral does. So we love estrogen, but there are benefits of the other hormones. So vaginal hormones obviously fix the urinary and genital symptoms. Progesterone, and I like Mike.
Before we get into the progesterone, leave the estrogen, I also want to talk about, well, first of all, my question was also going to be, if you have somebody on a patch, it is a transdermal form. Is there ever a time when the patch is not working and so you go to a gel? Is there any reason to really use a gel? I see so many women now who are seeing kind of, what do you call that, concierge medicine. And it's so groovy to have all of these different gels. And I don't know that there's any medical benefit.
Yeah, so it's so funny, actually, because there's so many different thoughts. There's so many different people's preferences. So there's a big menopause person who teaches a lot, very evidence-based person. She loves gels. She says, like, I love gels. I think gels are great. They're every day. You put them on. I tend to like patches for some reason. And the answer is look at testosterone, right? When we give it to men, they've got gels. There was a patch. It didn't really go that far. There are now oral testosterone agents that are different. There's injectables. The same is true for estrogen. There's a menu you kind of figure out. And just like testosterone for men, they don't always absorb. I find that gels, they don't always absorb. And so if you have a patient, I had a patient today. She's on a 0.1 gel and her estrogen was like 30 or like 25, and she's miserable. She's having hot flashes. She's having brain fog. She's like not feeling good. I don't think she's absorbing this thing, right? Like, I don't think she's getting what she thinks she's getting, and she didn't like patches. So she could take an oral estrogen. She could do the ring, the fem ring. She could take injectable estrogen, which is actually very inexpensive, and we use all the time. We use kind of, just like injectable testosterone. We'll do weekly injectable estrogen, which is pretty good. So there's like, again, if you're just learning this and you're just starting here, you're not going to start there. Now, what I caution you, and the guidelines are very clear on this, we don't love compounded products. We don't love pellets because there's no regulation. And you get pretty super physiologic doses. And so my take, and I'm very opinionated on my pellets, is actually not that I hate pellets. We have an FDA-approved pellet for testosterone. We have Testopel. I'm fine with pellets. I'm fine with the delivery system. I believe if these companies cared about women the way they say they do, and they weren't just trying to get everyone's money, they would do the work and submit the data and actually prove safety and show us that they work and show us they're amazing. And until they do that, I am not going to stand up and say that it makes sense because it's predatory.
So if you see a woman who comes into your clinic on pellets, estrogen, progesterone, not just the testosterone pellets, they're getting their labs checked almost monthly or every other month, and then sometimes changing the pellets depending on the labs. What do you do with that woman?
Education is everything. I'm not there. So I have my New Year's resolution this year was meet people where they are and give them what they need. Is read the room, meet the patient, talk to the patient, get to know why they are doing what they're doing, how they feel about what they're doing. And then my job is to educate. My visits are long, and I do that because they become my friends. And like, it really is about where can I push and where do I not push? And you kind of figure out with your patient, because if I shame her, if I then tell her, you're doing dangerous and stupid things, and this is monstrous, and you're spending so much money, and you're a dummy, and your doctor's a dummy, guess what's going to happen? She is going to smile and nod and say, yes, doctor, and say, listen, pretend like she's listening to everything I say. And she walks out of the room and she says, to hell with her. I don't like her. I'm going back to the doctor who listened to me, and I don't mind paying money for the pellets. And so this happens every day in our clinics, and we think we're literally leaving a room and we give ourselves a mental high five and we're like, we're awesome. We did a great job. And that person is sitting there saying, I am never coming back to this office again. It happens every day.
It's good to keep that in mind, right? Absolutely.
And I will say, actually, my patients who come to me and they'll say, Dr. Rubin, I am afraid of hormones. I will never take a hormone. My mother had X cancer or this thing. I'll never take a hormone. I listen and I hear them and I push gently, and I get to a place with them of education of facts and where their fears, understand their fears, validate their fears, but show them data and meet them where they are, but also gently push of like, it's not true. Can we get you to a place? And I will tell you, the patients who ultimately start dipping a toe and then they jump in the water and then they swim laps, those patients are my most aggressive proselytizers of hormone therapy. It's the wildest thing. When you can turn a Republican to a Democrat or a Democrat to a Republican, they become evangelists. It is the funniest thing because they were so set in their ways. And then they feel great on the other side. And they're like, oh my God, I'm telling every friend I've ever met that this is what they have to do, right? It's the funniest thing. It happens all the time.
Okay, so we talked about the different types of formularies. I like that. That's exactly what the goal was. So people are aware all the different kinds of estrogen that are out there, the way it can be prescribed. So you have someone who's pretty stable on the estrogen. I guess, first of all, how long do you leave a woman on before you decide, yes, this is the dose for you?
Oh, there's no magic here of, again, I usually will see someone, 2-3 months after starting to get a sense of how they're doing. And then you adjust as you need to. Again, there's no rules. That's what actually makes menopause medicine a little challenging is you have and fun because you have to use your brain and you have to sort of like let your brain be like, oh, well, let me try this. Let me try that. What am I afraid of? Oh, I'm not afraid of anything. Let's tinker here. And you got to get your patients on board with that too. So there's no rules, I would say. To give it 2-3 months.
Yeah, practically speaking. So you wouldn't change it every week, right? You just give it a little bit of time, see how things are going. Couple of months seems to work. And then you get to the end and the major vasomotor symptoms are gone. You're happy with that dose. What tells you that she might benefit from a little progesterone?
Yeah, so if she has a uterus, we're definitely going to want progesterone to protect the uterine lining. You could use a Mirena IUD is fabulous, especially for your perimenopausal patient who's still bleeding. We love progestin-based IUDs because then they don't bleed, they don't get their low ferritin levels and their low irons, and they're not exhausted all the time. And it's birth control, which you still can get pregnant in perimenopause, and it protects the uterine lining. So you don't necessarily need oral progesterone, but you still could use it. And we find progesterone, and I typically use micronized progesterone. I use 100 milligrams every night. That's what I do. You can go to 200 milligrams every night if they get the sleep benefits. And we find that most people, about 2/3 of patients do great with progesterone. About 1/3 of patients have progesterone sensitivity where they feel bloated, they get rashy, they don't feel good. They're probably the same patients that get PMS or PMDD and things like that. Like there are some people who don't do great with progesterone. And so IUDs are great for them. There's other medicines and things like that we do for those patients, but about 2/3 of patients do fabulous with just a good old-fashioned micronized progesterone. That is a bioidentical form of progesterone. It helps with sleep. It goes into GABA receptors, so it can improve mood as well. And it is quite lovely. I had a patient today say, "Oh my God, progesterone was the magic. I am sleeping again. Dr. Rubin, my libido's back up because I'm sleeping again. I love progesterone. I wish I had named a child progesterone. It is so excellent."
So is that the main benefit then of progesterone? If a woman doesn't have a uterus, adding progesterone, if she's having some sleep issues, or are there other benefits besides?
We don't know the answer to that. So the book says it's just there for uterine protection, right? That's sort of what the book says. But many of us in this space see the sleep benefits significantly. And we're not afraid because the data does not show increased breast cancer risk, does not show increased blood clot risk. And so we feel very comfortable sort of adding progesterone for patients who want to try it for sleep. Occasionally for anxiety reduction, we can try it as well. I'll have a handful of patients on it. And if they don't have a uterus, I basically give this to them and I say, go play, right? You could take 100 to 300 milligrams for sleep, see if it helps you. If you don't notice the benefit or it makes you worse, then you don't need to take it. Again, it's kind of a thing you can play with a little bit. But if they have a uterus, you want to give them progesterone because you don't want to build up. Estrogen grows things, your hair, skin, and nails, your libido, it grows things. So it can grow the lining of your uterus. And if you don't have that progesterone to help keep it thin, you could potentially develop uterine cancer. Now, this isn't something that happens immediately. This is not like, oh my gosh, I smelled estrogen and now I have uterine cancer because I didn't smell progesterone in my other nostril. So you can stack them a little bit, right? And kind of do one at a time and go, and get yourself used to one to kind of see what it does.
Is there ever any time to just start estrogen and not progesterone in a woman who has a uterus?
Yeah, I think it's totally fine to. If you have a woman who's like aching of hot flashes and she's miserable, give it 2 weeks. Give her estrogen for 2 weeks to just see what the estrogen does. Add the progesterone from there. Like this is not like oh my gosh, this is life and death medicine.
I think I misspoke when I asked that question. I think what I was asking was start as in a woman who has a uterus. Right. So you want to add the progesterone as protection. So, but is there ever a situation where you would start the estrogen first? And okay.
Yeah.
All right. I just make sure I asked that question correctly.
Absolutely. And some people, if their sleep is their worst problem, you could start with progesterone. There are some people who think, oh, we should always start with progesterone because it's helpful for sleep and it's progesterone in perimenopause that people are bothered by. I don't buy that, to be honest. I think estrogen is always going to be sort of your workhorse, but you were not wrong to start with progesterone. Now, I have a lot of perimenopausal women where I start with testosterone because I do think that, they're still cycling and it actually is their low testosterone that's making them drag much more than it is the estrogen or progesterone.
Clearly, if a woman has her uterus, just being on estrogen for a prolonged period of time is not the safe thing to do.
Right. That's not a safety thing.
Yep.
So you want to always use progesterone if they have a uterus.
Okay. So we touched on the estrogen. We touched on the progesterone. So now let's move into the big T, testosterone. So at what point do you decide, right? Okay, this woman can also benefit from testosterone. She's not getting, well, first of all, can most women get what they need from just the estrogen and or progesterone? Or do you think most women need a little testosterone?
So I don't think everybody needs everything, but I think everybody should have the menu to get to make informed choices for themselves. I think that's my big push. Now, plenty of patients, I have a few theories here, a little bit non-scientific and very opinionated because of what I see every day in my clinic. I cannot unsee the fact that we get women on estrogen and progesterone and they're doing great. They're happy. They're doing fine. About 4 to 6 months into starting testosterone, there's this moment where they come in and they all say the same goddamn thing. They say, Dr. Rubin, I feel like myself again. And I have heard that statement so many times, and they don't talk to each other. They're not in cahoots. They don't know that they're saying it. And they all say the same thing. And it's so crazy that I have now been able to use that to be just give it that 4 to 6 months to kind of let it kick in. And I sort of think this happens with men's testosterone as well. I think it takes longer than we give it credit for. I think it takes a little while. And so we know low testosterone in women is kind of an age-related thing. So it's kind of in your 30s is when things start to drop. So when you see these women in their 30s coming in with UTIs, it's actually a testosterone problem. It's because the microbiome is changing because of the lower testosterone. So giving them vaginal estrogen or DHEA, very helpful. And potentially giving them testosterone to help with their libidos is very helpful. We also get women who actually will say their stress incontinence is better, and there's data to prove that because just like men, the urethra is full of testosterone. We know the urethra for females is a very testosterone-driven muscle. So I do find it helps sort of with mild stress incontinence and things like that as well. Again, most of our data is for libido, like our major data. If they're perimenopausal, I think it's reasonable to start with testosterone and only do testosterone. But I think for my menopausal patients, I rarely start with testosterone. It's typically sort of add-on to the estrogen and progesterone therapy. And again, it feels serious because we never talk about testosterone in women. It's not that serious, right? It's about a tenth of what we give to men. It's very easy. It's very generic. It's not expensive. They put a little generic testim on their calf every day. And in about 6 months, they wake up and they're like, woo, I see color again. This is so lovely.
And what do you think about all of the salivary testing that's done to look at levels, especially when people are utilizing testosterone?
I think the same in men. We don't use salivary levels to look at men's testosterone. We don't have data to look at salivary levels for women's testosterone. From what I understand from the experts, it's probably not that terrible, meaning it may be similar, it may not be awful, but none of our research is based in salivary levels. And so when you're charging patients lots of money for things, you have to question, is this real? Is this valid? Is this actually better than the standard? Or is this just a cash grab? And listen, I have a cash pay urology practice. I am a proud taker of money, but the reality is I charge for my expertise. I charge for my time. I charge to give really good advice to people and spend time examining them and talking to them and getting to know them and being able to hire staff that can can really answer the phone and answer their questions. I don't charge for fancy packages and fancy lasers and fancy things that they must get. For me, it's if you're going to do experimental things, then you must do them under the guise of this is an experimental thing.
Yeah. And then, we already mentioned pellets. When we look at the pellets, we know there's a testosterone pellet, but it's dosed for men. Do they have any that are small enough that would be adequate for women? No. So it's only going to be some transdermal for the most part.
So the pellets are compounded, so we don't love them. So we tend to use transdermal or male testosterone and female dose. So I love generic 1% testosterone gel in a little tube. A man takes the whole tube, puts it on his chest every day. A woman makes that tube last about a week or 10 days. You could take an androgel pump and you could kind of, do a quarter pump or a little half a pump every other day or something like that. You're looking at 5, again, 10 times less. So if we say a 50 milligram dose for a man, kind of a 5 milligram dose for a woman. So find a testosterone and kind of dose it that way. We use GoodRx coupons. So you're talking $100 is a 10-month supply. It's not expensive. You could use a compounding pharmacy for a gel, but we don't need to because we tend to use these generic male products in our practice.
So you mentioned that we were talking about estrogen a little bit, but we didn't really get into the idea of checking levels. Predominantly, I know in this area, of sexual medicine, we really think you go by the symptoms. Am I giving you a high enough dose? Is it taking care of your symptoms? We kind of know what's going to be a safe dose, what's going to be an uber dose, right? But at what point do you feel, maybe I need to check some labs? Or do you do a baseline in everybody, no matter what, when you start? And if you think you hit a steady state, you check again to keep them there? Do you check annually?
I have a theory, I always say there's the book answer, there's the Instagram answer, and then Dr. Rubin's answer is usually somewhere in the middle. And it really is kind of in the middle. I love labs. Listen, we use labs for everything, for thyroid levels, for insulin, glucose levels, for parathyroid hormone, for iron levels, for testosterone, for the idea that we can't use labs. When the FDA requires lab testing to get these products approved, right? They look at the Cmax of these levels of these doses to ensure safety and talk about the dosing. To me, it makes no sense that we don't use labs for this thing. But the book says you just care about symptoms. We don't look at labs. But here's where labs can be a little helpful, right? I have a patient who had a fem ring and she emails me and she says, oh my God, my hot flashes are back. My night sweats are back. Everything is terrible. I said, oh my gosh, let's check your blood levels. What's going on? And her estrogen was 0. And we said, oh my gosh, your femring's not working. What happened? And she went to change it and it was gone. She didn't have it in because she probably had a bowel movement and fell out. Now, again, did I need labs to tell me that? No, she could have just checked for her femring. But the reality is her numbers were telling me there was a problem. So for that patient with a 0.1 patch who was still having symptoms, and we checked her level and it was 30, well, I would expect a 0.1 patch to kind of get me more towards like 50, 60, 70. And so I'm like, I'm not loving this patch for you, right? And she's having symptoms and the numbers are low. To me, it tells a story. So I never typically go just on numbers or just on, it's kind of this story. And when I tell stories, I like to get as much detail as possible. Now, my story is not always a correct story, and sometimes we tell ourselves false stories, but I use stories to weave together so that I can come up with a hypothesis of kind of what's going on with the patient. And the beautiful thing about data and knowledge and staying up to date on all this is you change your story as you go. We're constantly changing our stories as we go. I love labs. I use blood tests from LabCorp or Quest, wherever the patient goes. I often use fatigue as my diagnosis because the insurance companies like that, and every patient is fatigued. And if they are still cycling and in perimenopause, I like checking on day 2 or 3 or sometime early in the cycle because that's when their levels are the lowest. So I'm checking a trough more than I'm checking a peak. And if they're in menopause, you can check at any time and sort of look at what their levels are. Now, the guidelines say you should check a total testosterone level if you're going to give testosterone therapy. And there's no number with which you're like, oh no, you want to make sure it's not so high. Like if they have a very high, if their testosterone is 300 and they're not on any testosterone, I probably wouldn't add testosterone at that moment. But you're just looking to kind of see what the baseline is. So that's kind of how I approach labs. I go into a lot of more nuance I do a lot of lab discussions when I teach, in our course, to really get doctors confident of what are you afraid of. And when you look at the menstrual cycle and you think the low is not 0, the low is like 50, right? And then it goes to 150, and then it comes back down. Why perimenopause is so painful is because your low is usually 0 and your high is like 800, right? Like you're having these crazy fluctuations, which think of the receptors in the body that's full. Now it's empty, then it's full, then it's empty. No wonder women get ADHD in perimenopause. No wonder they can't remember what a pen is called, right? Like their brain is having a seizure.
Yeah. You mentioned this already, but let's get into it a little bit more. When do you add DHEA or use DHEA instead of testosterone and instead of something else?
Yeah.
Talk about that.
I don't really use oral DHEA in my practice. That's not to say you couldn't, and there's some data. I've never seen data compelling enough to make it part of my recommendations. And so I don't typically use oral DHEA. Vaginal DHEA, on the other hand, a product called Intrarosa, which is approved for GSM, is a magical, wonderful, incredible product because it is the only FDA-approved product that actually has androgen in it. So we think of the tissue, the pelvic floor, the vagina, the urethra, the bladder, full of both estrogen and testosterone receptors. And the new GSM guidelines, they really highlight the fact that there are androgen receptors in here too. And so estrogen may not be the full story. We love vaginal estrogen. I think it might be my middle name, but this idea that actually we probably need more androgens in this tissue. And so this product, DHEA, it's a nightly suppository that goes in. We publish data that it prevents UTIs, which is fabulous. We, of course, know that it helps with pain with sex and orgasm, arousal, lubrication, all of those things. And so it's a lovely, lovely product. We often have to do prior authorizations to get it through. But when you get it and you can get samples in your office if you're allowed to, it's really a magical UTI prevention medication that is supported in the AUA guidelines as well.
Wonderful. Well, that's great. I think we really talked a lot about systemic things. Before we wrap it up, I do want you to talk a little bit about what's going to happen on Thursday with the FDA and the unboxing, menopause with trying to get the black box label off of the vaginal estrogen.
Yeah, so we got a call a few weeks ago from the FDA and the commissioner, the head of the FDA, Dr. Marty Makary, who is very vocal on hormone therapy and the misinterpretations of the Women's Health Initiative. And for anyone listening, he has a whole chapter in his book called Blind Spots that's all about hormone therapy. And so he has invited for a roundtable of people to come together, of experts in the field, to talk about menopause and hormone therapy. And so we'll be there on Thursday. And it's going to be live on YouTube, and you can go on YouTube on their channel to watch it if this is after the fact. And we're hopeful. We have a lot of things we're going to talk about. There are 3 urologists who are invited into the room. 2 of us are going. And one of the things we're going to really talk about is the box labeling on vaginal hormones. And we're going to really work hard to say that the box is not telling the truth. There's not a single truthful statement about the box labeling. And so that box is killing people. It is killing people. I'm actually going to tell a story at the FDA, hopefully, about how that box tried to kill my mom. My mom was in the ICU for 6 months, and they wouldn't give her her home dose of vaginal estrogen because they said it causes blood clots. And we know it doesn't cause blood clots or stroke or heart attack or probable dementia. And she had a catheter. She was in a coma for so long. She was immunocompromised. And I said, you have to give her her home dose of vaginal estrogen. And they said, but don't you know your mom is sick? I said, of course I know my mom is sick. That's why I want her to not get a UTI and die of urosepsis. And so I had to fight. I had to put together a whole presentation. I convinced one team. Then I had to convince the ICU team. And everyone kept saying, but it causes blood clots. Then I wrote the prescription myself with them watching in the EMR. And the pharmacy wouldn't dispense it because they said, wait a minute, we got an alert that this causes blood clots. We can't give this to your mother. Finally, the tube of estrace made it up without an applicator. And the nurses said, we don't know what this is and how to give it. And I had to roll up my sleeves and show them myself. This is what I did, being on the GSM guidelines, knowing this data better than anyone else on the planet. And yet this is what happened to me. And so what does everyone else do? That box is hurting people. It's hurting us. So we're going to the FDA and we're begging and we're screaming and we're yelling because this needs to change for all urologists, for all humans, for all people, right? This is really hurting our patients. Anyway, I'm hopeful the FDA is great, and I guess we'll find out. And I'm so happy to be here. So thank you so much for having me.
Thank you so much, Dr. Rachel Rubin. This was really fabulous. It was wonderful insight. We really wanted practitioners to be able to just really see if they wanted to get involved in prescribing hormone replacement therapy for their patients. How's the best way to do it? Is it safe? You have made it very clear that it's very safe. And especially all the advocacy work that you do on behalf of women, whether it's for vaginal estrogen or systemic estrogen or just sexual health in general. So thank you so, so very much.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Ogrodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.